Lastly, I'd like to introduce myself. My name is Catalina Sol. I'm the Chief Programs Officer at Untitled Pueblo, which is a community-based clinic here in Washington, D.C. And like many of you and our partners here, this issue of mental health in Latinos is very close to our model of care. We will have 3 speakers, but we have 4 experts at the table who will be available to us for questions and answers. The first speaker will be Jenny Crawford, LCSWC. I'm a little bit different with the Maryland letters. She is the Director of Integrated Behavioral Health at Community Clinic CCI. In that role, she supervises the behavioral health staff, and as part of the organization's senior leadership team, she works to integrate mental health and substance abuse services into primary care at all CCI locations. Ms. Crawford is the former Deputy Director of the SAMHSA HRSA Center for Integrated Health Solutions at the National Council for Behavioral Health. In this role, she oversaw training and technical assistance to 100 behavioral health grantees who are integrating primary care for adults with serious mental illness. She received a law degree from Antioch School of Law and a master's degree in social work from Catholic University. Our second speaker will be Jennifer Pock, MPH, LCSWC. She's the Director of the Montgomery Cares Behavioral Health Program at the Primary Care Coalition. She oversees administration and day-to-day operations of the Integrated Behavioral Health Program, which operates at 10 partner primary care clinic sites in Montgomery County. She also serves as the advisor on issues related to behavioral health as they relate to other programs and policies of the Primary Care Coalition. Jennifer received a BA from Brown University, a master's in social work, and a master's in public health and maternal and child health from the University of North Carolina. Following Jennifer, we will be hearing from Freddie Martinez, MSCSAC. He is the court liaison mental health therapist with Arlington County Department of Human Services. Mr. Martinez has 17 years of professional experience assisting harmed and injured youth, children and families, and communities to overcome their emotional and psychological problems. Mr. Martinez holds a BA in psychology and MS in education and human development and a postmaster certification in addiction and counseling studies from Johns Hopkins University. And last but not least, we will not be hearing from Dr. Martins as a speaker, but she will be available to us in the question and answer sessions. She is a chief child psychiatrist in the Child and Family Services Division and associate medical director in the Behavioral Health Division of Arlington County Department of Human Services. She works closely with Freddie on the program model that they'll be presenting. So without further ado, I'd like to ask Ms. Crawford to come to the presentation, and thank you very much for attending this session.
I am Jenny Crawford, and I work at CCI Health and Wellness Services. This is our new name. We've been known in the community as Community Clinic. And so I'm also going to show you a few slides just about CCI to kind of give the context of our conversation about integrated care. So Jennifer Pock and I talked right before this. We both thought we were going to give you the slides on why integrated care and why that's so important. And basically, what we all want to say to you is that this is essential for all populations, that we look at the needs of the whole person. And so what we're trying to do is integrate behavioral health services, mental health, substance abuse, other behavioral health services into primary care, or primary care into behavioral health, depending on where the client or the patient, consumer comes to get their services, so that we are treating the whole individual. You would be amazed at the statistics, which I didn't include here, on just the number of all of us, of people who have co-occurring disorders, mental health disorders in primary care, medical issues. With diabetes alone, the national prevalence rate is 50% of people with diabetes have a co-occurring mental health disorder. So I'm going to talk to you about the evolution of integrated care, and we're still in the throes of it. I know a lot about it. It takes time to actually implement it. I would say I joined CCI last November. I have a previous relationship with them doing integrated care that I'm going to explain to you. But we really ramped up last January and doing a lot of the things that you're going to see that we're doing now. One of the things we did is change our mission and our vision statement. And I was the voice at the table to make sure that that our mission statement talks about providing integrated teams, integrated care. Here, you see the fourth line from the bottom of this. Because I think it's really important that when we're doing integrated care, that it be first and foremost in everybody's minds, and that it be incorporated into our mission and our vision statements. And so again, in our vision statement, with the whole group at the table, and later the board working on this, we made sure that we had language in there that addressed the whole body healing for all as we travel the stages of life. CCI started originally in 1969, became incorporated in 1972 in this one old house in Rockville. And now you can see that we're in 8 different locations in Montgomery and Prince George's County. And just the whole evolution. As the Federally Qualified Health Center, our service area is Montgomery County and in the northern part of Prince George's County. And you know, the population grows and grows. I'm going to show you one statistic that breaks down 21,000 people, but normally we say that we're serving, our numbers show that we're serving about 26,000 primary care patients, and another 30,000 Maryland WIC consumers, participants, and with the largest WIC program in the state. So you can kind of see just the progression over time. And right now, one of the things we're doing to grow is to have patient-centered medical homes at all of our sites, which definitely, the 2014 standards, if anybody's familiar with those, definitely include the whole integration of behavioral health and primary care. So that's just to give you a little context. The recent report I ran of 21,000 patients came from 134 different countries. But the biggest group of patients that we're serving are Latinos. And although 25% were born in Spanish-speaking countries, when I went down and looked at all the countries from Central and South America, half of our patients, because many were born here, are in fact Spanish-speaking. So what I'm going to present to you today is the model around health integration that we're using for everybody. Certainly we've got some unique issues, clinical issues, with the Latino population who we're serving. And again, this is just a slide to remind ourselves, you know, way back from 430 BC, this idea that we need to be treating the entire person. So in terms of evolution, 5 or 6 years ago, I wrote a grant to SAMHSA, the Substance Abuse and Mental Health Services Administration, to provide primary care at family services where I was employed running their outpatient mental health services, because we'd had several adults with serious mental illness die suddenly for chronic health issues, and although we were treating their mental health, we had no idea what was going on in terms of their physical health. So that project had just concluded, but what came out of that was a relationship with CCI, who initially sent nurses over who were outposted to our outpatient mental health clinic, who did primary care screenings, not primary care, but screenings, and helped those patients get across the street to primary care. That didn't work as well as it needed to, so it transitioned into actually CCI building a physical satellite clinic in that outpatient mental health center. And that goes on today to integrate care for anybody in that part of Gaithersburg, Maryland, but also with a particular focus on the adults with serious mental illness who are served by family services. I will say, you know, if you look at a spectrum of integrated care, this is much harder. It's doable, and I don't know if any of you have done it, but doing it between 2 different organizations who are on 2 different electronic medical records and 2 different staff with 2 different sets of organizational cultures and policies and, you know, vacation days of when things are open, you know, holidays. I mean, it's definitely doable, but it takes a tremendous amount of attention and work. So let me talk now about what we're doing at CCI. We have posted or outplaced bilingual Spanish-English, although we're trying to find some folks, always more Spanish-speaking social workers, but also some folks with other languages, because we do serve so many people with different languages. And it's hard doing the work just through the language line or with a third person in the room in an intimate kind of therapy setting. But we are providing the mental health services. I'm going to talk to you about how we're doing that. We are working on trauma-informed care. We are doing substance abuse screening across the board. Certainly we're doing primary care. We have dental at several of our sites and family planning at all of our sites. and then WIC at 4 different locations. So when we're looking at integrated care, these are the things that we're aspiring to have as components, which is care management, and that's hard in a busy environment. So we've been blessed to have had a grant through Care First, and we hired community health workers, and we've continued to keep them even after the grant was over, and are looking to expand and have additional community health workers who are all bilingual, all working in the community, can go to consumers' patients' homes, can meet with them in the office, who are working as lay staff to help patients with self-management goals, with case management needs, across the spectrum in terms of whatever they need. And we're trying to focus some of their work, because the need is enormous, some of their work on specific populations, specific needs, asthma, diabetes, and depression, so that we can really try to see if we're having a change in terms of patients' ability to care for themselves after they get more information about how to manage their health with those issues. We are providing evidence-based treatments with effective medication management and psychotherapy. The psychotherapy is different, because certainly than it was when I was in an outpatient mental health center, because we may only see somebody one time. Now, I'm going to talk in a minute about trauma, and that won't surprise you that we have people with just enormous traumas and histories, and we're not going to resolve trauma in one visit. But because so many of our Latino patients are also uninsured, there's a financial hardship to come in and commit to 10 weeks or even 4 weeks in a row. We try, if they can, that's what we want to do because it's best treatment. But we are trying to be as successful as somebody in the moment that one visit when they're there. And then I'm going to talk to you about the expert consultation for patients that are not improving, that we're doing diagnosis, trying to track outcomes, and we're doing a process called stepped care for depression. All of this requires team-based care. So in our centers, we have our physicians, our nurse practitioners, our medical assistants, our nurses, our clinical social worker, our community health workers, our front desk, our billing people, everybody is there. Everybody meets together for a huddle for 10 minutes a day to talk about anybody who is a high need, who's coming in that afternoon, to make sure that we're doing all that we need to do for them, or just making sure that if someone's coming in for vaccines, that those are set up. It's just to keep us coordinated and communicating. But everybody's clear that our successes with patients is based on us working as a team. I'm going to flip through this integrated care core competencies, which is important, but you'll see the slides, and talk about these key components. So we're screening everybody now, we have been screening once a year for depression. Now we're screening at every visit, any child over age 11 and all adults using the PHQ-2. If we get a positive, then a PHQ-9. If somebody already has a history of depression, we just use the PHQ-9 questionnaire. We have another questionnaire that we're using for postpartum depression. The core of what we're doing that really works are warm handoffs. So, and I love this slide. So, our providers have tremendous pressure in an FQHC to see 18 to 20 patients a day, and that means they need to be clicking. So if behavioral health is going to work, they need to support those providers. So we have a schedule that's set up like this. It has spaces in the schedule throughout the day for ongoing scheduled therapy sessions, and it has spaces all day long that are flex spaces, so that if a patient comes in and the provider says, the patient's crying, are they screened high, it looks like moderate depression, I've got the perfect person that I want you to meet. They're not going to say it's a therapist because of the stigma. And that person's tied up for the next 20 minutes because the whole team knows this schedule. But if you can wait for 20 minutes, I'm going to bring that person in and introduce you. And at that point, the provider may move on, and it may be the nurse or the medical assistant who grabs the mental health therapist who comes in and into the exam room and begins to work with that patient. Now, that patient may or may not want to stay and turn that into a whole session. We may do some breathing around anxiety, some problem solving, or we may be able to get that person to talk enough that we can get them to agree to come back for a session. But we have to have the flexibility throughout the day to do this, to do enough billables to bring in money to sustain this component, and the flexibility in the moment to see those patients. We're also screening, and we have been since April, all adolescents and all adults at every visit for substance use issues. I'm getting reports. I'm doing ongoing training at our sites around this. It's grown every month because everybody's getting better and better at all the screening. And so all the providers have been trained to do a brief intervention, which is a brief counseling session with anybody who screens positive. Anybody who screens really more on the end of this is an alarm bell or an addiction can get a referral to treatment. We have all the treatment providers in Prince George's and Montgomery counties. We don't have all the relationships with all the providers yet, but we have a referral specialist who can immediately do a referral right then on the spot when the individual is willing to go. This kind of shows you what instruments are built into our electronic medical record to do the substance abuse screening, to get the score, and there's what's called a clinical decision to support tool in the EMR that tells the provider this person needs a brief intervention, this person needs a referral to treatment, or this person's doing fine. We're just going to encourage them to drink safely or to abstain. Motivational interviewing skills are important. That's an area where we've trained some staff. We need to train more. I don't think we could ever quite train enough on motivational interviewing. Trauma. We're part of a Kaiser Foundation learning community, really fortunate, one of 14 FQHCs to take this journey to learn to become trauma-informed. So what this involves is we're going to screen a very small group of kids with obesity and adults with uncontrolled diabetes. Our hypothesis is maybe those populations have a trauma history, and that's impacting their ability to have a better health outcome. And then we're going to provide treatment to those individuals who consent if there is a trauma history. So all 14 FQHCs participating in this have picked out some population that they're screening. And then we'll take this organizational wide as we figure out the workflow and what works and what doesn't. The other cool thing we have is a psychiatrist for 16 hours who understands integrated care. She's spread her hours out through the week. So we've got our medical providers can pick up the phone at any point during their week and call her. If she's not with another patient, she'll pick up. It's usually a 5-minute conversation, and she will walk them through how to titrate somebody up or down on a psychiatric medication that they have not normally used and may not be as comfortable with. There aren't enough psychiatrists in the country to provide all the psychiatric care. So my goal is to expand the capacity of our primary care providers with the support of Dr. Larson, who I think they're learning to trust, to be able to do more. So we're also, as we journey into the patient-centered medical home, providing more care management. We have some RN-level nurses who are doing care coordination for patients who are complex, and we've defined who those patients are. And some of our community health workers I mentioned are working on pediatric asthma, uncontrolled hypertension, uncontrolled diabetes, and then those with diabetes and depression. We have tough productivity expectations. So to make this work, we need our behavioral health full-time people to see 6 patients a day, warm handoffs, weekly groups. And the heart of integrated care is communication, right? So we have these daily huddles, special huddles for complex, expensive patients, a shared problem list and a single EMR, which is just wonderful since having done it, with 2 organizations where I couldn't see. We can internally flag each other about patients. Behavioral health staff are required to append their notes, their therapy notes, unaddressed trauma, multiple generations of trauma in our Latino population, lots of grief, kids who've been separated from parents worrying about children they've left behind in their grieving, constant anxiety about those children if they're separated from them, a sense after getting here of feeling depressed and unsafe, lots of economic stress, particularly women. We tend to see more women in therapy who truly feel isolated, and lots of conflicts between adolescents and their parents once they're unified after being separated. So I can come back and talk at the end about our successes and our challenges and our next steps, and I'm going to stop there for my colleagues.
Well, thank you so much for coming, and I will try in the next 10 to 12 minutes to give you a very broad overview and also the flavor of what the program that I work with is doing in Montgomery County. And what I'd like you to come away from this is just the power and the potential of integrating behavioral health in a primary care setting and how that can both meet the needs of the patients and the providers and some of the broader needs for mental health in the whole community. So as Jenny mentioned, we didn't put a lot of context slides in here, but a couple of things I would throw out to you is that we know that almost 80% of primary care visits involve a psychosocial component. So almost, the majority of patients coming in for a primary care visit have something going on. Referrals to outside mental health treatment have been shown to be the least successful of any specialty referral in primary care settings. And we also know there's a really high occurrence, as Jenny mentioned, of co-occurring behavioral health and chronic medical conditions. And it's been shown that mental health conditions actually cause many chronic health conditions, and as well, chronic health conditions can cause mental health conditions. So they really go together. You can't treat one without treating the other successfully. And then also, as Jenny mentioned, there are not enough mental health clinicians and psychiatrists in the country to begin to meet the needs of what we see in terms of behavioral health needs. We have to do something to be efficient to meet the needs of a population. So this is a population-based approach to care. Just to give you a very broad overview, Montgomery Cares program is a public-private partnership between PCC, Primary Care Coalition, and Montgomery County DHHS, and 12 community-based safety net clinics that are their own private nonprofit organizations, and then 5 hospitals in the community. And then these are other things that Primary Care Coalition does to support the primary medical care and the services that patients in these clinics serve. Montgomery Cares patients are low-income, uninsured adults in Montgomery County. This is the mission of the program that I run. We are based on the collaborative care model. If you don't know what that is, if you Google impact and depression, you will come up with sort of the initial program that the collaborative care model is built upon. And it's a population-based model. We collaborate and support primary care providers. We utilize consulting psychiatrists, behavioral health care managers. Universal screening for us is also a key component, and then providing treatment. We're at 10 clinics now, 10 clinic sites now. We work with 6 clinics all across the county. They all have different missions. They have sort of different ways of doing things, different focuses. So it can be quite challenging to work with all of them. So I thought I'd start just with a really brief case example of a patient that we've worked with, just to give you an idea of what it might look like. A Latino woman was referred to one of the care managers at one of our clinics for depression. I believe they screened positive on the PHQ-9, so the primary care provider referred them to this program, the care manager, for assessment. During assessment, she got a full biopsychosocial information on the patient, as well a lot of background on her medical issues. And indeed, she did have many, many depression symptoms. She scored very high on the PHQ-9, was not doing well functioning. And then her medical problems involved increasing urinary incontinence, and that was contributing to her depression, her inability to function. She presented that case at one of our team meetings with a consulting psychiatrist, and the consulting psychiatrist is able to recommend a specific antidepressant that also would assist her with her urinary incontinence potentially. And then the primary care provider was able to prescribe that at her next medical visit. at the same time, the patient kept coming in to see the care manager and getting supportive counseling and therapy, behavioral activation to kind of get back on track, address some of her depression symptoms. She was on the antidepressant, so the care manager was monitoring her response to that and how she did over time. And then the care manager went the extra step and followed up on a referral to a women's gynecological clinic that had sort of gotten stalled or was falling through the cracks. And she was able to get her appointment moved up. She was able to get in. She's about to have surgery to address this urinary incontinence problem. And she's generally feeling much better about life. And I think that's just a really good example of how integration works. You're working with a whole person, you're addressing a whole bunch of different needs at the same time, and it helps people get better. So these are the roles that we have in our program. We have care managers, and they're all bilingual. That's one of the absolute bottom line requirements in Montgomery County in these clinics because many of the patients are Spanish speaking. We have nurses, RNs, social workers, counselors, or psychologists. They have a variety of roles. They are the behavioral health clinician at the clinic, educating about diagnoses and treatments, doing assessments, following medications and reassessing to see if patients are responding, and then using motivational interviewing, behavioral activation, and some other brief therapeutic methods. And because these are all low-income patients, they have a lot of very practical needs that need to be addressed. They need to be connected to community resources. They just, you have to start with the basic things often with people. Our consulting psychiatrists, we work with Georgetown University Department of Psychiatry as one of our partners. And I want to say that any way to connect to organizations like Georgetown, academic organizations, is a great way to support psychiatry in these programs. It's very, very hard to find psychiatrists and sustain contracts with them. So they've been a real champion of this and a great partner. They provide consultation to the care managers and the primary care providers. They reach out, they actually walk the halls, they do seminars one-on-one. We've done online things. Any way to provide more education and support to primary care providers to feel more confident and comfortable in their role identifying and managing and treating common mental health disorders. And then the primary care provider for the majority of our cases is the prescriber, not the psychiatrist. The psychiatrist is not seeing the majority of patients. They are providing recommendations and guidance in our program primarily through the care manager to the primary care provider. And then the primary care provider is the prescriber of medication. So it really takes everyone being on the same page. I can't say enough about the importance of having a model, a clear model, at least in your mind of what you're trying to do. Otherwise, there ends up being someone who's the social worker or the counselor who everyone thinks they do different things and they do everything, and it can get very unfocused. So it's really important to know what your targets are. Our program's main targets are depression and anxiety, including post-traumatic stress disorder, and then identification and brief interventions with risky alcohol use, the SBIRT model. We will take referrals for any type of behavioral health issue. But when it's a more severe issue, such as a serious mental illness like schizophrenia or bipolar disorder, for the most part, we're not providing or suggesting that their care be provided in the primary care setting. We're facilitating a connection or a referral to another specialty behavioral health. And then the stepped care model that Jenny referred to is the core of what we do. It involves regularly reassessing symptoms of depression and anxiety over time and making sure that patients respond to them. And aiming for a remission. And this was so refreshing to me. I worked in community health settings for many years, and often as a therapist or a mental health provider, I think we tend not to have numbers or goals. It's a little more squishy than that. So having these very quick tools to assess level of symptoms and whether or not there's progress is really nice, and we can actually show it graphically over time. And I'll show that to patients. I'm like, see, your scores have actually come down. You might have had a bad day, but over time, you're getting better. And then if patients don't improve, change the plan. Add a medication, change a medication, add some additional therapy, or make some additional outside referrals. The goal is that they have to get better. And if they're not, something additional needs to be done. This is the staffing ratio that I try to aim for now in this program. One full-time care manager per 2,500 to 3,000 patients, and one psychiatrist. I'm sorry, this is a mistake. It should say 20,000 patients, not 200,000. That would be really efficient. But one psychiatrist per 20,000 patients. And this is with the understanding that the psychiatrist is really only doing the consultation part. So actually, we have a little bit more psychiatry time than this per population, and our psychiatrists actually provide direct services to patients who haven't improved or are more diagnostically complex, or that can maybe benefit from a couple of visits from a psychiatrist and then be turned back to the primary care provider. And then a couple of comments that teamwork is just essential in this model. Everyone needs to learn how to communicate differently than they've been trained to do. Primary care providers need to trust the care manager and the consulting psychiatrist's assessment and evaluation of patient, and just be willing to prescribe medication without doing a full evaluation themselves all the time. The care managers need to learn how to speak in medical terms to doctors. They need to know how to read labs. They need to know how to pronounce medications and diagnoses that they're not familiar with. So there's a component of supervision and ongoing training that's just essential, and it's across all of the disciplines, and that takes time. There's no way around that. And then I think getting the right people has been just essential. And I would say the first thing is they really have to have a passion for working with this type of population and patients. They have to be comfortable with this model of care. You have to have psychiatrists who are comfortable doing consultation and not seeing every single patient themselves. You have to be able to communicate across disciplines and with different types of patients. And ability to tolerate a lot of different settings and a wide differences in workflows, because every single one of these clinics is different, and being able to adjust to that and fit in is essential. And then for the care managers especially, they have to be really independent and be able to be more than a behavioral health clinician. They have to be an advocate for behavioral health in a medical setting and be able to promote the concepts. So we try to serve 15% of the patients at the sites, and we try to constantly be looking at the bigger issues about whether, what is the level of integration, what is the level of primary care provider knowledge and comfort with behavioral health topics, what are workflows, how is documentation being done. We've customized templates and reports in the EMR. Let's see. These are our quality measures that we've developed, we're working on still. Two of them have to do with depression screening. We are promoting that every single patient is screened with the PHQ-2 in their primary care visits, and then if positive, the PHQ-9 as well. We're looking at what % of patients with high screens are seen by behavioral health providers, and then whether they get better over time. So this shows you a little bit over the past year what the depression screen scores did. These were new, so I think people just started documenting. But clinics are doing a really pretty good job at screening patients. And then I would say the devil's in the details for these programs. You really have to get in and figure out every single step of the way how things can run smoothly. So let's see. So I think some of the opportunities are that the ACA is going to require integration at some level. There are HEDIS measures that are being tested now for integration in depression treatment in primary care settings. Partnerships are an opportunity. Training programs in different disciplines are just now starting to get up to speed on training for work in this setting. And I think that will be more. And then I think there's starting to be ways to show long-term and short-term cost savings for these models of care. That's it.
Good afternoon to all. Hello? Yes. When you go out and do system shopping, you try to figure out what's the best system that may work according to your needs. Not necessarily all the systems are universal solutions. So in Arlington County, our system was developed to be focused on making the families self-sufficient and develop their potential. It's strongly centered in the family. So what kind of system can you think about that to create? And at the same time, that system has the particularity of being accessible, that families can access the system. We listened this morning, all the different barriers. Language, making it impossible to access it. Insurance, they don't have the insurance. So the system has to work around solutions for the system, for the insurance to not be a barrier on that. And also, we listened this morning that the waiting list is another problem. So if you're going to design a system, you may have to target the waiting list part. Sometimes they have to wait like 1 month, 2 months to get the service, and that's not working if you have a crisis. So the approach that the Arlington County has developed is based on these principles. It's centered in the child, it's focused on the family, and it's community-based. So it has to be comprehensive, continuous, integrated, and accessible. But accessing what? What exactly that you will be delivering in that kind of system? These are the list of services that can be accessed currently from any family in the county that wants services from the department or from the local government. I'm not going to mention those, but those are in the slide. My presentation in this part is going to focus on the accessibility part, which is the in. So every time that you speak about the system, you speak about in, process, and out. So you get a client, you get a family in need, you do something with them, you provide some services, and then you achieve some goals, and when the goals is achieved, you close the case, or you refer the case. So in that applies for any kind of system. So in our specific case, I'm going to present about the in part related to substance abuse and mental health, specifically speaking to the Behavioral Health Bureau in regard to family and children. We have more departments. We have the adult departments. We have a recreational department, but I'm not going to address that part. This is about Latino, how they can access the service. I want to center on that. So the first thing is intake, how they can access the services. nobody can be left behind into accessing the service. So under that principle, any kind of family that feels that they need support and help from the Department of Human Services, they can go through this process of calling and getting to have an intake process. It's a universal, one-stop intake process for all the families. They just call this number, and they can get into the service. Then you can ask, well, but that's kind of tricky, because if it's one entry point, you may have like a lot waiting list. You may have like a lot of people waiting to get the service. Fortunately, we don't have that right now. We have improved so much that the waiting list for the children to get services in Arlington is between 8 days to 10 days maximum. So we're moving very fast in making this accessible for them. No matter there is an insurance issue or there is a difficulty in getting the transportation to get there, we get to the solution to get that done. So who referred the cases? Schools, probation officers, social workers, medical doctors, and the family in itself when they get to the school and they listen to information and then they're calling us. 2 points of entry we have in the system. 1 point of entry, it's the building in itself of the Department of Human Services. In that building, there is a person who processes all the intakes. And then there is another point of entry. You say, what that could be? That point of entry is the courthouse. It's the courthouse in itself. And that's the position in which I'm based or located at. My title is a court liaison. So the department thought about, you know what, let's put a mental health therapist in the courthouse. So when the family comes to the courthouse, and they are also trying to get the help from the courts to control their own children, someone is doing the screening and helping them out. So the intake process, every company may have it or any system, you do the initial screening. That's what I do in the courthouse. When the family walk into the court building, I do the screening, mental health. Also, my other partner in the main building in DHS, they do the same. We assess the financial situation. Do you have insurance? You don't have insurance? How much you can copay? You can't copay? And we do an assessment based on a slightly scale. They can access the service. We complete a full comprehensive intake, and by the end of, after 2 hours, the whole psychosocial, all the forms are completed, and that person is ready to get services. And from that point on, they can be assigned to a case manager or a therapist. And that case manager or therapist will be working with them on an ongoing basis. If they don't qualify, it's because their symptoms are not sufficient enough to require outpatient level of care. And therefore, they will be referred out to other institutions that may help them in a lower level of care. So what are we making this accessible? What are having in place to make this accessible? One is the bilingual staff, the bicultural quality, that they have to understand the cultural background of the clients, and that's the cultural competence. And the important part is also the treatment approach. We do the matching process. If the child doesn't speak English, we try to accommodate that. If the child is limited in his language capacity, emotionally speaking, then we try to provide therapeutic recreation as a way to circumvent the approach. So, and the language support is also, we do interpretation and language line. This is part of the same services that we provide. The psychological evaluations, the core diversion, and this is important. The core liaison, it's an office that is located in the courthouse. Now, picture this. You are in the courthouse, and then family with the child cross the building, goes to the 4th floor, and they say, you know what, I can't deal with this kid anymore. He just came from Honduras or El Salvador, and he is uncontrollable. We cannot deal with him anymore. You judge, please do something, because we cannot as a family. I'm not the father, I'm just the uncle, and they send it to me. I have no idea what I'm going to do with him. Those are the kind of cases that we are receiving on a daily basis in the courthouse. Approximately 55% are Latino community, Latino cases that come to the courthouse. And the problem starts there. When there is no case manager, there is no therapist in place, they don't have insurance, and they cannot navigate the system. And the only step is into the courthouse and see if someone can help them out. That's where I jump in. When I do the assessment, in this particular case, I realize that this child has tried to hang himself 3 times in the closet. Okay, so we have an issue. If the system is not designed that way, that finding will be coming later on the road, not right there. And so early detection is an important factor. And once that's what detected, the case was called into the courtroom. And then the judge listened to the parents' request. And then I already collected their signatures for releases of information, so I can speak legally about the case, and the parents, the legal tutor acknowledges the situation. So the judge says, Mr. Martinez, can you please tell me if you already talked to them or what's going on? So with a disclosure in my hand, I say, Your Honor, we have a case that this is what's going on, these are the symptoms, these are my recommendations. I called the department, and we have a therapist that can be assigned. The appointment, I set the appointment up. They will be able to get someone to interview them in 2 or 3 days. And if he needs emergency services right now, I can help them to even escort them if needed to the emergency service or call the emergency service. Someone can come to the courthouse and do the further evaluation. So I develop a plan, like a crisis solution plan, and the judge goes with it, approve the recommendation, and then postpone the case like in 1 or 2 weeks to see how that progresses. In the meantime, I take the child and the family, go to my office, call emergency services, call CPS, call all the people involved, and then get the ball rolling so they can access the services on time and not when everything is too late. So it's been effective, very effective, because, and I'm going to show you some data about that. For example, this is, you can ask, okay, what's the department doing to address the need of the children? So in DHS, the way the system is developed, the government, the DHS government, has a lot of services, as you can see in this image. We provide a lot of services. And the court also provides other programs that are not here, but they don't do that as much as DHS and the private providers. Someone asked the question, can you tell me about what are the challenges that you find in your daily work, working with Latino, how they can access the services? I have already mentioned some so far, but the bilingual is a common one. The legal advice, they don't have legal advice. In one case that I found, this child just came from El Salvador. He just landed with his uncle and the relatives, and that night the police was patrolling the streets, and he was caught in the police in a public urination in the corner of the building. So he was taken into the court system for doing that. And then that's one of the important parts, how they can legal advice about when they get in trouble with the law because their cultural limitations. Also, the intergenerational language. The father doesn't speak the language of the child. That's a common factor. I guess all the practitioners, they have that. So let's do family therapy now with that. So that's the reason why I say therapeutic, you have to match the therapy to the client needs. Maybe, as I mentioned, therapy recreation, bilingual staff to do that work. The distance to access services and transportation, well, in Arlington, that's not a big issue, but it's still the family that may not have the resources. They have to use TOCAMs or some kind of assistance to use the public transportation. And we are strongly working in peer group activities. That's very important. Now, this is the other part of my example. So you have the family. We are working, targeting the family. And then you have the courts, and then you have the DHS, and then you have the family assessment planning team. I'm going to explain that in a while. That's a committee that gets together and talks to the family. and then you have the private providers, and then you have the schools, and then the police. So the police talks to the court talks to the DHS talks to the school talks to the police, and that's for one referral case. And then the court calls the schools, and the DHS decided to refer the case to the community, this committee, because DHS feels that the family needs more what DHS can provide. Remember the previous one, the whole list of services? There are some that we don't cover. So DHS decided, you know what, I don't have that funding. We need to request a special funding for that specific service that the family needs. In this case, the child needs residential. So we're going to ask for this committee to pay for the residential. So the family goes to the committee, and the committee hears the family, and they decide if they pay or not for that based on the symptoms. This is family-centered. The family makes decision in what the child is going or what the child is going to. And the private providers. So it's the whole circle of interaction in between everybody to make just one decision about the level of care the child needs. And then you see the whole list of services that if those services doesn't work, then he needs more, like adoption or home-based therapy or day treatment. So it increases in the level of care as it progresses. So in the corner, you see a guy with the binoculars in the corner. That's the community service board. It's a community, it's people from the community that volunteer, and they are like oversight and trying to see how all these services are being performed. And they provide some advice and policy changes in the way the Department of the, Human Services is delivering the service. And then if you see in that other corner, the Community Service Act, that pulls a pool of money aside. So this committee can purchase some services. So in between oversight and support and policy making and the Community Service Act, all these three, and the courts, all these three entities have to interact to make this happen. It's a system that interacts in between each other. Now, specifically, someone asked me about, can you give us an idea about numbers about mental health diagnosis in children in Latino community? So from my office, the court liaison office, we have had in 1 year an average 152 cases that I've served. Those ended with a diagnosis of mental health, 126 with any kind of mental health diagnosis, and 45 with substance abuse diagnosis. And then the time is up, but I'm going to mention one last slide, which is the major issue are depressions and substance abuse problems, are the major common issue, anxiety, depression, and substance abuse problems in the Latino youth population. And that's it. The whole, I start speaking about the service, shopping services, system shopping, and that's one example of how that may work.
So as you can see, it takes a village to raise a child, and it takes a village of providers to also help those children and families. I'm Edwina Martins, and I'm a full-time child psychiatrist in Arlington County, and we are lucky to be able to have the services available. We actually have a part-time child psychiatrist. I've been with the county for 5 years. I worked a couple of years as a part-time provider, and for the past 3 years as their full-time psychiatrist, child psychiatrist, so we have adults. And I wanted to just briefly give you an idea about the behavioral health needs and what we're seeing. Freddie did an awesome job describing sort of the whole system. And I wanted to mention that we do have a very diverse county, and we have a very diverse group of youth that we serve. And this slide was just to show you that we have over 60% of the youth that we serve are Spanish-speaking, or come from Spanish-speaking homes. And we have about 23% African-American, and they are from a lot of the Central American countries, and El Salvador is like the highest group that we see. So that's important as we understand their experiences when we're trying to see them and understand what they've gone through. One of the things, and I know there was a luncheon on trauma-based, and I think one of the things that I wanted to highlight, if this works, we do see So people will have gone, so I see youth that have gone through an intake process, and their needs, they need to be assessed, and they need to require a higher level of services. They will be referred to me, and this is a sample of sort of 50 cases that I see, and I sort of went through and pulled some data for this conference. One of the things that we see a lot is there's a lot of trauma and a lot of complex trauma. And you see here that about 70% of the youth that we serve, so this is not just the Spanish speaking, but overall, have experienced trauma. And you see that the largest category is under abuse and neglect, and this includes both physical and sexual abuse, especially for the girls, sexual abuse is pretty high. The second, and also neglect, and some of that neglect has to do with parents working a lot of hours, not being available. So some of it is sort of economic circumstances and other challenges. The abandonment, absent parent, again, I think Freddie alluded to that, others have mentioned the fact that we were seeing children that are coming back and reuniting with families, and that's been presenting a lot of challenges, both for the parent and for the child. And the child dealing with a lot of those issues of the having been abandoned. Domestic violence is also an important piece. So I pulled, let's see if this moves. So in looking at, so I sort of said, okay, let's look at what are some of the diagnosis presenting symptoms. So you see that depression was actually the highest diagnostic category. So we had about 60% of youth presenting with depression. And about 20% severe enough that they were suicidal. And we actually have 20% of the kids had either been hospitalized or require sort of intensive inpatient services. Sometimes it would be like an evaluation done inpatient because they weren't safe to be in the community. Anxiety is the second highest category. And again, you have PTSD, which is often people say, well, if you have trauma, does that mean that everybody has PTSD? And no, because you can have somebody that's presenting with depression, anxiety, ADHD symptoms, a lot of other things. And part of the process is to really look at those children and discuss, because they often don't necessarily reveal the trauma until you've worked with them for a while and they trust you. And there's that comfortable level that they know that people are going to not only understand but support. So part of showing this is that I think we do need to acknowledge that this is that the trauma and the impact that it has is important to acknowledge. Some of them are just realizing for the first time their own, oh, I have gone through this. This really has had that impact. And connecting their actions with their emotions and how do they interconnect. So for them, that's also sort of that process of accepting, I have something that I have to work on. And earlier on, they were talking about the transformative healing, and I thought that was really good. He had listed the acknowledgement, the acceptance, and then the compassionate care, which I think is so important in treating them. And then the commitment, the fact that, I think Freddie had put a slide about the fact that the comprehensive care, and we don't have a set time for how long we're going to see somebody. It really does depend on where the patient is at, the family is at. We work with the children and the families, and so we go with where it's needed. And I think it's great that we do have the ability to do that. And I work with a lot of other therapists, case managers, so provide consultation, do a lot of direct care. And that's how we serve the needs of our youth, both Latino and others. I guess our time is up.
Okay, so we want to have some opportunity for questions and answers. We don't have a lot of time because, as it happens, everything that's run meeting that's running is running a little bit late, so we're all a little bit late. So I'd like to see a show of hands of how many questions we have, so I can make sure we get to everybody. So okay, we've got 1, 2, 3, 4, 5. Okay, so let's start with you. Sure.
Yeah, go to Mike.
I just wondered how you accommodate immigrant families that work long hours. How does your service provide? Can you hear me now? Okay. How do your services provide for families that work long hours and on weekends? And so how do you accommodate being able to see them, service them in the evenings and on weekends?
That is one of the challenges. I think we actually have a policy where some of the staff, we used to be open until 9 p.m. for a lot of, I think Monday through Thursday. We are now open until 7. There's clinicians that I can't quite get this to work, but
Nah, it's fine. It's just for the recording. So please don't know. Can you talk in it though? I like to.
oh, okay.
It's for the recording.
So we do have clinicians that work later hours, and so some of them may work 4 days and they work sort of the longer evening hours, but that's actually one of the requirements that we have. I also work, so I see a lot of the late afternoon, so I see more than half of the children we see are like 15 to 18, and then we have a lot of middle and high school students, and we don't want to keep pulling them out of school. So we do, so our busy hours are between 3 and 7, so I think we are aware of that because a lot of the families can't. So we're closed on Saturdays, but we do have a lot of the evening hours available.
Are there other members of the panel that want to answer? Are people able to hear in the back?
I think
with this mic?
all of our clinics that we work with have different hours, some evening, some weekend. But I think that's one of the powers of integration, is that it offers treatment in an acceptable location that doesn't have the stigma of going to a mental health facility. And then we do a lot of work by phone with patients. Once we're already working with them, care managers will follow up and reassess patients on the phone. And just the understanding, I think, that Jenny mentioned, that patients aren't always able to come in for the traditional 50-minute sessions 8 weeks in a row. You just have to do what you can. And I've been really, really amazed at how many Latino patients want treatment with medications, because they're able to do that and they get some symptom relief. It's one way of treating mental health disorders, and people sometimes want that because it fits into their lives.
Okay, next question.
I have a question from Mr. Martinez. How does legal status and guardianship factor into these court cases? Because you had mentioned how this young person arrived on an uncle's doorstep. So I'm not quite sure if there was a parent involved in another country. So did this uncle have guardianship? And then or if this child arrives illegally, does the court still address the child's problems? And how is that covered, let's say, through insurance or other means, especially if it's not a parent involved?
In that particular case, migration released him to the uncle and gave him a paper. And that validates in the juvenile court the final guardianship on him. In other cases, that has to be presented to the judge, and then the judge grant or not the parenting rights if there is enough proof. If there is no proof, then usually the judge notifies the Department of Human Services, and one social worker has to step in the court and do the job of assessing where is the family, how is everything doing, and then come back to court with the recommendation if he's going to be in foster care or he's going to be assigned to a relative.
So there would be no chance of deportation of the child. The child was here.
Yes, we do our best to get him to get the parenting through a family member using the partnership with the courts and the Department of Human Services.
Question number one.
My question is about billing for Jennifer and Jenny. What are some of the barriers that you are experiencing in terms of billing for the services, for the behavioral services that you are providing, and what's had to happen for you to be able to bill for those services?
So the biggest barrier is that so many of our Latino families are uninsured, right? So we're on a sliding scale, and an average number of primary care visits per year is about 4. An individual probably can slide to the bottom of our scale and afford that. What's harder is paying, for week to week, a treatment series, of 8 to 10 weeks to treat something. So we are offering group, and we have a lower sliding scale in the group. But that's out of pocket. We do, because I am worried that someone comes in and they're on the sliding scale and they're highly suicidal, right? So we have an obligation. So we're saying to them, this is our sliding scale. This is where you fit on that scale. This is what you would owe for the session. But go in, meet with a therapist or the doctor today, and we'll work out a billing plan with you in the future. Because I don't want that to be such a barrier to treatment. So they may have to pay an extra $5 or something over time for that session. But it's a way to manage that so they're not highly anxious about it. We do bill in Maryland for Medicaid through value options, and so there is a whole workflow to that because we do have to stop with the patient and get authorizations. So they have to sit with us long enough to do what value options requires on the computer, a questionnaire, submit that to get a series of sessions authorized for them. But the people with Medicaid, that's a little barrier compared to not having funding.
Jennifer, did you want to?
Well, then I would say I'm very extremely fortunate in that we do not have to bill for our services. My program staff are funded under Montgomery Cares to pay for the salaries. So that's just we're really lucky to be able to do that. Clinics that don't have my program but that serve Montgomery Cares patients can also be reimbursed for those visits under Montgomery Cares at the same rate as a primary care visit at those clinics.
And we do that too with Montgomery Cares.
So what I'm hearing is that through value option, if the client has, if the patient has insurance, you can bill for those services.
Absolutely. Well, if they have commercial insurance, we can bill commercial insurance too, and we do.
There's a question here in the front, and then one more in the back, and I think over there. Did I see a hand back there? Was there any other? Okay, so 2 more questions.
Yeah, my question was mentioned briefly. I work at a clinic when we were doing worm handoffs, and one of you mentioned, saying, instead of saying, I want you to talk to a therapist, saying, I think there's somebody really great that you can talk to. But hearing a little bit more about how you all have dealt with that stigma of getting patients to meet with a therapist, and especially with maybe recently arrived immigrants with their parents, or their mom or dad might feel shame and doesn't necessarily want their child to talk to somebody, and how to make that linkage.
So I have found this to be really easy. It's a script, and everybody has to stick to the script, right? So that we have to convince the medical providers, which is not difficult, to not use the word therapist, psychologist, or psychiatrist, right? We don't hide that, once a patient's connected. But we are saying, I hear you're feeling really sad today, or I hear you're feeling really anxious today. I've got somebody who on my team who would be great for you to talk to. Let me go get them and introduce you. There's a term that I've coined called the transfer of trust, right? So if the patient trusts the provider, the medical provider, and that medical provider hands off to me, a social worker, that patient immediately, I got creds, they're going to trust me, and then I can talk to them, and then I can disclose, I'm a social worker and I work here to help people. It's not been an issue.
I think just to add, I think that's the importance of collaborating, because I do think that once, if you can say something about the person, if you know that the person is likely to connect, I agree. I think they will trust. They tend to go more. If I'm referring somebody, if somebody refers to me, if counselors at school, if they know who I am, they're much more likely to present it in a way that the child is going to want to come in and be seen. If I have to have the child see somebody else, if I can do the same. So we really try to get to know each other, because I think that makes a big difference, and the same thing with the primary care providers.